The first question for our panel today is, how would you explain diabetes to someone who has never heard of the condition before?
Okay, Manisha, followed by Satyan, please.
I would probably ask the patient or the person if they knew anybody who had diabetes. But if they didn't, I would say that diabetes is a condition where the sugar is not processed properly, and there can be a number of reasons why. So the body doesn't, the blood, actually, your blood in your body has too much sugar.
Thank you. And Satyam?
So first of all, I know the question said to somebody who has no idea, but I would still ask them the question, what do they understand, if anything, to ensure that I allay any misconceptions or any misunderstanding. After that, I would try and explain in layperson's terms using as little jargon as possible, but still reinforce that it is a serious condition, because I hear so many people who think I just have a little bit of sugar. So what I would normally say is that the level of sugar in the blood is too high. I sometimes use the term glucose, but I prefer to use sugar. It's too high. The body can't use it or store it properly. And then I go on to say that we all need sugar in our bodies to use it as fuel, but it's just that when you have diabetes, you can't use it properly because it's in the wrong place. And the reason for that is either that we don't make enough insulin, or the insulin that we make is not working properly in our body. And very often I will use an analogy, either the lock and key analogy, or an analogy I've used more recently, which works really well with patients, is I ask them if they drive, etc. And I'd say, if you're driving from, say, Leicester to London, and you had to fill your tank with fuel, if you put the fuel into the petrol tank, you'll be able to get to London quite easily and you'll be fine. If, however, you took the actual fuel and just poured it all over the car, you still put fuel on your car, but you're not actually going to be able to get anywhere, and in fact, you'll cause damage to your car. And so what I then say is that insulin is the key that opens the petrol cap and lets you put the fuel where it needs to be, rather than everywhere where it shouldn't be. And most people resonate with that quite well. And using that sort of analogy makes them realize that it's the effect of diabetes and why it's important, because otherwise all people think is, I'm scared of sugar, I'm not going to take sugar, and that's it. But to explain that it is important to have sugar for a source of energy, just that you can't process it properly.
Okay, great. Thank you for that. Charles, would you like to go?
Yeah, I totally agree with what Manisha and Satyan has said. I think for me, it always depends on what the person living with diabetes or the individual on the streets health literacy is, because then you can now sort of provide a response that suits their health intelligence. And some of the things Satyan said are things I also use as well, but I often try and refer to it as energy. So I normally would say that diabetes is a condition defined by how your body uses the energy it gets from the food and drinks it takes in, and how your body's insulin, which is a hormone that's produced by an organ in your body called the pancreas, actually manages that energy. I think once you use the word energy, it does help. I tend to bring in the pancreas organ into it, again, depending on the health literacy of the individual. And that helps sort of put into perspective that there is a supply and demand process going on, and all about how the energy in your body functions and how you store it and how that's actually manipulated within your body system.
Great, thank you very much.
Thanks so much for that. That was a great explanation.
Yeah. The second question, I feel like we kind of touched on it about how does it develop, but maybe I could specify it to possibly type 2 diabetes, as that's got a different onset. So how would you explain that type 2 diabetes develops in patients? Charles, please.
When it comes to how it develops, it's the multiple factors I always try and address. I think because of the false stigma that comes with diabetes, I'm usually very cautious about how I explain how it develops. So I often say when it comes to type 2 diabetes, there are multiple factors that are involved. So you have the environmental factors, you have the individual behavioral factors, and you also have the genetic factors. So depending on which of these factors trigger your diabetes, which leads your body not being able to use the energy within your bloodstream, as well as the insulin production from the organ called your pancreas, that would determine what kind of diabetes you would develop or what type of diabetes you would develop.
Right, thank you very much. Satyan?
So to answer the more open question, I would maybe say that there can be a number of reasons, but then if I then talk about type 2 in particular, I basically just simplify it as much as that your pancreas in your body doesn't make enough insulin to keep up with your body's demands, or that the insulin that the pancreas makes for you isn't working properly in your body. And then I'd go on to talk about what causes that to happen, whether that's an elevated high cholesterol or obesity or blood pressure, etc. And some of these things contribute to it. I would talk about risk factors, and I know we're going to talk about that later. So I'll then talk about those things, but then also I may at this point, in terms of how it develops, I would talk about the signs and symptoms as well, and try and explain them. So to explain to people, you may feel tired because you can't use the fuel that your body's taking in. But essentially, I would break it down to that your pancreas isn't making enough insulin, or that the insulin your pancreas is making is not working as well as it should inside your body.
Right. Thank you for that answer. Manisha?
To follow on what Satyam said, I also use the lock and key analogy, and I often say that, you know, sometimes you are feeling tired, and that's because all the energy or the sugar is in the blood, but your cells aren't getting that energy, and it's because either the locks are rusty and the energy, you know, the key can't work, so the insulin, which is the key, can't open the locks to let the energy in. So that rust, I'll then sort of correlate that to extra body fat and obesity, and maybe use the term insulin resistance. But I don't often say that at the beginning. I'll just say that, you know, we need to polish those locks up. So that's like with linking that to weight loss, and perhaps the mechanism of metformin, if that's going to be a discussion at that time. So I'd use the lock and key analogy quite a lot. And I'll also say sometimes you just don't produce enough insulin. So it could be a combination, because you will get some type 2 people with diabetes with type 2 who are actually quite slim. So not everybody is overweight or obese.
Thank you.
Thank you.
Charlene, please.
Okay, so coming from my background, the psychiatric, some of the medication that we give actually causes weight gain. So sometimes we do have to, when we're prescribing someone with specific antipsychotics, we do need to have the conversation about weight gain and possible diabetes onset happening. Again, we do, like everyone's has said before, it's not always related to weight gain, but from my field, the majority of it is. Therefore, we encourage a lot of healthy eating, being more active, and looking out for them signs and symptoms that were mentioned before, like fatigue, frequent urinating, and we take it from there, really.
Okay, thank you. That's a very interesting point, actually. Okay. The next question we have is, can diabetes affect people at any age, and any further developments on this question?
I would say obviously it's about if diabetes can affect any age, and the answer is yes, but obviously it depends on what type of diabetes that we're talking about. So if we're focusing, obviously we know that there are different types of diabetes. So yes, diabetes can affect any age of patient, but then it depends on the type of diabetes that it's related to.
Okay, thank you very much. Manisha?
I'd say that generally type 1 patients tend to be younger, but this is just a generalization, and generally age is a risk factor for type 2 diabetes. However, you do see type 1s present at a much later age, and sometimes you see type 2s at a much younger age. So lifestyle and obesity can be a factor for developing type 2 at a younger age, but also genetic factors can have an influence as well. Thank you.
Thank you.
Satyan?
So sometimes what I will sometimes do is go through the fact that, you know, type 1 is called juvenile onset and type 2 is mature onset. But then, just as Manisha said, I would then say that you can get type 1. So you can see type 1s at a much later age, and you can see type 2s at a much earlier age. And we are seeing, so I'm from Leicester, and in Leicester, I think we had the really sad claim to fame of the youngest type 2 patient with diabetes in the country. I think it was age 14 or something. So there is a bit of a blurred line between type 1 and 2 as well, and also not to forget the very small numbers, but there are those patients with the MODY, with mature onset diabetes of the young, which is a genetic mutation. And I know it's only 1%, but if I was really trying to explain this to, say, a clinician or someone, I would absolutely go through that as well, because it's so underdiagnosed and forgotten.
Thank you. Charles, please.
Yeah, just as a follow on to what everyone has said, and especially what Satya just said, I think it's also being very mindful that the landscape of diabetes type has changed over the years, and with obesity becoming a major problem, you're going to have childhood obesity as a problem, which means you're going to have an early onset of type 2 diabetes in people who are young. But having said that, also other type of diabetes like neonatal diabetes, so diabetes in children less than 6 months. Again, that's a genetic problem. And similar, the MODY diabetes Satyan talked about, which is majority onset diabetes in the young, that's also a genetic problem. You do have the type 1 diabetes, you have the type 2 diabetes, you also have a type 1 diabetes that's often called ladder, which is also found in the adulthood. So there's quite a spectrum of diabetes. So I think it's very important that we sort of make emphasis on that spectrum that can happen from day not to actually any age. But as Tonya said, it all depends on what type of diabetes we're talking about, the risk factor words for that.
Okay, thank you all for the answers. Very insightful, actually.
The next question I have for our panel today tackles adherence and compliance issues, and I just wanted to know how you ensure that your patients are keeping up with taking their medications. As you know, the maximum daily dosage of metformin is 2 grams per day, and as the most modified release and immediate release formulations of this drug have a strength of 500 milligrams, this could possibly see someone taking, on this dosage regimen, taking up to maximum of 4 tablets per day. I was just wondering how, as pharmacists, you ensure that the patient does this. Thanks.
So as a practicing community pharmacist, I see this all the time. And essentially, first of all, is to ask open questions of the patient. And quite often, things like sometimes people do forget to take the medicines. Do you have any of these problems? And if so, what's the reason why? You have 2 types of adherence, poor adherence. One of them is, or compliance, and one of them is intentional. The other one is non-intentional. So do they intentionally not take the medicines? And if so, what are the reasons? Can I, as a pharmacist, try and allay some of those concerns? Asking them about any side effects, how to take the medicines, etc. A very clever professor once taught me, he said, you've got 2 ears and 1 mouth, so use them in that order. And I don't always do that, but listening to the patient really gives us a real idea of how they feel about their medicines, and then we can talk to them about it. It's very easy just to wag the finger and say, you must take your medicines. And in terms of talking to patients about keeping up with their medicines, looking at strategies, whether it's reminders on their phones, if it is just unintentional poor adherence, or if they have a real concern with the medicines and they think that one of the medicines is causing a side effect, then not to try and brush it under the carpet or trivialize it, but to talk to them about it head on. And most importantly, explain to the patient how the medicine works, why it's important to take it, and what the long-term and the short-term benefits are. If you say to a patient, you must take this medicine because it reduces your blood sugar, they're going to say, well, do I really care? But if you say, this medicine will help you keep your blood sugar under control, which prevents you from potentially going blind, which prevents you from having a heart attack, or prevents you from having a stroke in the future because we have your blood sugar under control, amongst other things, then it sort of makes it real for the patient. It's not just taking tablets for the sake of it. looking at the polypharmacy and looking at if we can simplify their regimes, and always, but always not just focusing on the diabetes medicines, because we do that so easily, but looking at the antihypertensives and all the other medicines, remembering that this patient may have multiple comorbidities, and therefore they may well be taking significant numbers of tablets, and trying to make sense of it for that patient. So it's a complex area, but I think the key for me is to listen to the patient's concerns before I jump in there and try and give them lots and lots of information.
Thank you so much. I think, yeah, the point about polypharmacy is a really big issue, that a side effect from one thing may prevent them, a patient, from taking another medication. And like Charlene, you said earlier about weight gain and weight loss, which I'm going to come on to you in a second. I think polypharmacy is a great issue that you've raised. Yeah, Charlene, if you'd like to speak next, please. Thanks.
Okay, so I work on a ward, so I get to see patients. Actually, I dispense the medication. So what we do now is we empower them. So therefore, we leave it down to them to come to the clinical room at the correct time. If someone avoids us to take their blood sugar levels, we then, like was said before, we then ask them why and what they do in the community. And we try to let them tell us when they want to take it, how they want to take it. Some people like it to be dispensed, some don't. And we just make an open forum. We have dialect with them, and we try to empower them. And also we avoid the mother-child situation. So as long as they're fully psychoeducated about what will happen if you miss your dose, we will try and encourage them, but it's their decision at the end. We will still keep going back to them and asking them, and reinforcing, do you know what happens if you don't have your insulin or your metformin? Do you know what would happen? Sometimes they do come around, sometimes they don't. And then we then bring in the pharmacist to come and talk to them also, but we support them and follow them. They are very much in lead with that. And we've got good rapport, and we've got good compliance when it comes to diabetes on the world, just because we leave it to them. At the end of the day, there's only so far that as clinicians we can take them, and it slowly develops into a habit.
I see. Yeah, thank you so much for that. I think the contrast between you working in a hospital ward and when we have Satya speak about being in a community pharmacy, I think that independence of you coming to collect the medication is another thing that can even help to improve the compliance. So I think that contrast between you and what you just said, Satya, was very interesting. I'd like to take it to Charles next, please.
Yeah, I was just going to add, I'm sure Manisha and Tonya will also have comments on this as well, because for us to do a lot of diabetes work in general practice, we often do a lot of diabetes clinics for people living with diabetes. I think exactly what Shalina said, it's about empowering the person living with diabetes to have ownership over their care, ownership over their medication. And part of that process is reinforcing good education. And good education has to be reflective of the individual's health literacy. So, trying to take into cultural differences into that, taking into socioeconomic differences into that as well. Even the biopsychosocial element of it, their mood, their experiences, the risk of depression, diabetes, burnout. There's so many factors to take into before you actually concern yourself about either someone is taking their meds or not. I think the key thing, as NHS England always says, and I think all of us in the room agrees on, is about shared decision making. Making sure that decision is actually shared between yourself and the person living with the diabetes, and trying to give them that empowerment to make informed choices, but also accepting their informed choice, even if the informed choice is not the clinical desired choice. And at times, it's also finding ways of making the medication suit the individual, not just the disease. Because we often find medications that suit the disease, which is what every clinician wants to do. We need to find methods and medicines and process of delivering the medicines that actually suit the individual.
Thank you so much. Thank you for that. I think health literacy is also a very, I would say, essential topic that you've just raised here, in that you can only go as far as to say, or to explain it in a way that is accessible not just not for your patient, but for you to have that connection about, okay, this is why you should take it. Before, in Charlene's experience, where they would bring the pharmacist over to speak to the patient if there is no compliance or adherence, I think making sure that the patient has the health literacy to understand in the first place that this will happen, if this is the consequences if you don't take it, and these are the improvements if you do take it. So I think health literacy, amongst everything else you said, was an amazing point you've raised. Thank you so much. I think Manisha is next.
Hello, I just wanted to add to Charles and the other speakers, really, a patient's health beliefs are really important to address, because some patients really, they may understand the literature, they understand the complications that could happen, but their beliefs may be that they actually want to just use lifestyle and minimal medication. And perhaps, sometimes we may not understand all of their beliefs, and some of it's affected by their culture and their environment and their family members who have diabetes and their experiences. So all of this can have an impact on how they feel about their own condition. But really vital, as Charles has said, and many of our speakers today have said, is that you do have to inform, empower, and engage, because they might see you, for us in general practice, once, twice, 3 times, 4 times a year. But all the other days, they are managing their own condition and living with diabetes. So it's important to give them enough of a boost when we do see them, so that they engage and are empowered to deal with their own condition.
Thank you for all of your insight. I feel like I've personally learned a lot from just the range of points of views that you've all mentioned here. So
Yeah,
thank you.
definitely. Okay.
I had one other point to add to that, and that is another strategy I sometimes use around patient adherences. I will talk to them about the number of patients. So more than 50% of patients don't take their medicines as prescribed, and then go on to say, when this is diabetes, that is more than 65%. That's nearly 2/3 of patients. And then sometimes I'll throw it back at the patient and I'll say, why do you think that is? And when you say, why do you think so many people don't take their medicine how they should, they will come back to you and tell you what they think. And that is really telling you why they potentially don't, what their concerns and their beliefs are. So it's a different way. If you say to somebody, what do you think about taking your medicines, etc., it's very hard to tease it out of them. But when you ask them a generic question, like nearly 2/3 of people don't take the medicines properly when it comes to diabetes, why do you think that is? It's a really easy way to get some information from them to then be able to address some of those concerns if necessary.
Thank you.